متاسف. هتكلم على الكولانجي كارسينوما, tumoral and non-tumoral mimics and imaging features helpful in differentiation.
Good morning, everyone. Today I will talk about cholangiocarcinoma and its mimickers, whether they are tumor or non-tumor. First of all, cholangiocarcinoma is relatively rare, but in the Demirtaş Hospital, it's never rare. We always meet it every day. It's second common tumor in the liver. Any condition that leads to chronic inflammatory process involving the biliary system will be a risk factor for cholangiocarcinoma. It's adenocarcinoma type. As regards its growth pattern, we have first, it's mass forming and periductal, as well as, wait, I will laser point, as well as the intraductal growth. The most common form is the mass forming. It's irregular, has certain criteria in CT. As regards its histological pattern, it is, has fibrous tissue. So it's more hypodense in CT, have capsular retraction, stellate nodules, and microvascular invasion. In MRI, it has intermediate signal in T2 with cloudy appearance, and the most characteristic form, it has peripheral contrast enhancement, which when dynamic, it will be fill-in and will give rise to target-like appearance in diffusion image also. And we have here a CT axial image. This is the characteristic peripheral enhancement and the gradual fill-in and the characteristic washout, target-like appearance in diffusion rooted image and delayed image. And there is capsular retraction in the medial aspect, as well as the gross features, gross pathology will have capsular retraction. But as we know, radiology is not easy. We have a typical form of mass forming, hypervascular and mucinous form. As we said, that cholangio is a fibrous tumor. If it has stroma vascular, it will lead to misinterpretation and diagnostic dilemma. The vascular form, it's common in HCC, common in cirrhotic tumors, cirrhotic liver, has better prognosis. And as it is not fibrous, it will have arterial enhancement and wash out, it will looks like HCC. As we can see, if we face this in our diagnostic report, we'll see HCC, cirrhotic liver, heterogeneous arterial enhancement, and wash in. But this case is proven to be vascular cholangiocarcinoma. The other form is mucinous. As we all know, mucinous means rich in mucin, and it will have high T2 and have septation inside. This will appear as hemangioma because it will have high T2, and as we see here, in the axial, it has cloudy appearance, in arterial enhancement, early arterial, and this is the rect appearance. It's not looks like nodular enhancement of the hemangioma. So it is mucinous form. And the diffusion restriction is a clue here. Mostly hemangioma doesn't have diffusion restriction in the wall like this. The second form is periductal, infiltrating, is grow along the duct. And it have lead to duct narrowing and abrupt termination, long structure, and the thickness will be more than 3.4 millimeter. As we said, this is the most form we see in our radiology. This is soft tissue thickening at the hilum with hypoenhancement, upstream dilatation, and as we see the cavernous transformation in the portal vein because of the mass effect on the portal vein. And the last form is the interductal form. It appears as interductal filling defect or irregular duct or irregular thickening. As we see, there is soft tissue thickening here along the right posterior branch, and this is either extension or metastasis, and this is the filling defect inside the duct. So this is the interductal form. This is what I look when I write cholangiocarcinoma. This is my face, because there is a lot of mimickers of mass forming. The first one, sclerosing hemangioma, hemangioendothelioma, confluent hepatic fibrosis, pyogenic liver abscess, and hepatocellular carcinoma, especially the atypical type, like undifferentiated infiltrative, and the combined for lymphoma and metastasis, especially the solitary metastasis. Sclerosing hemangioma. As we know, how to report hemangioma? We all know that hemangioma is a light bulb, high T2, gradual filling peripheral arterial enhancement with gradual filling in. But what if there is fibrous inside the hemangioma? It will be sclerosing type, and this will be very difficult to differentiate from cholangiocarcinoma. we will depend on the other morphology of cholangio as capsular retraction, satellites in the liver, edge of the patients, all are this. We can see this is first reported as cholangiocarcinoma in the literature, but by pathology it proven to be Skerras type. The clue for Skerras type is the follow-up. We can see at first it have arterial enhancement like this, and then it's decreased in size. This is with the sclerosing. Second one is focal conferent fibrosis. I think this one is easy to differentiate because it's peripheral, wedge shape, subcapsular, has sharp edges with gradual filling in, so we can differentiate it easily. Like this. This is the edge is sharp, subcapsular, in background of liver cirrhosis, gradual filling in, so it is conferent fibrosis. The myogenic liver abscess, I think also we can differentiate it, but sometimes the abscess is not mature and is in the, like this, developing abscess. But the clue here, we can see some central necrosis that coalesce together with diffusion restriction. And as we see here, the diffusion restriction and central necrosis. The solitary hypovascular mets, it's really difficult, especially if we don't know that the patient have history of primary tumor. We can see this. The most common tumor that can send single mets is the colorectal. We can see here, this is 65 years old male, we have arterial enhancement, portovenous and delayed, but the clue in this case is this circumferential irregular thickening that's found in the descending column. It has early arterial and then wash out. Skerras type HCC, this is a rare variant form. It has fibrous stroma, so according to fibrous stroma, it will be similar to cholangiocarcinoma again, and it will have capsular retraction. The difference that the peripheral dilatation is with the Skerras type rather than the HCC. Here we can find arterial enhancement with washout. The clue for this is that you can find some internal foci of high T2. Cholangio is sometimes not high T2, it's cloudy more, but HCC has high T2. The body differentiated, it's body differentiated, so it will be similar to anyone. As we can see, it has heterogeneous early enhancement with areas of washout. Infiltrative type, and this we can see many in our radiology reports every day. In body imaging, we can see it's permeative growth inside the liver, but the clue is the diffusion restriction. It looks like not the target appearance of cholangio, but more diffuse, as well as it infiltrates the portal vein or biliary system, while the cholangiocarcinoma encased, not infiltrate. Combined HCC and cholangio. This is very nice case. We can see there is left loop heterogeneous focal lesion. In the right aspect, we have hypoenhancing with early arterial, and in the left, we have early arterial heterogeneous with washout. So it has part cholangio and the part HCC. Primary hepatic lymphoma, it's not common, but we can have clues as there is lymph nodes beside it. The diffusion restriction is very bright. It encases the vessels, as we can see. All this is hypodense lesion. We can see the encasement of the celiac trunk. Again, mimickers of periductal form, and this is again my face when I reporting like this. IG4, benign fibrosis, primary sclerosing cholangitis, gallbladder carcinoma with extension to the hymen, TB, and IBNB. We can see IG4. IG4 now we can face it every day. We can face it in the daily work. We can see that the biliary system is the second one affected. First the liver, then the biliary system. It has sclerosing cholangitis, multifocal biliary stricture, and areas of hyper enhancement. But the clue here is multi-organ involvement, as it involves the erythroperitoneum, the pancreas. We can see here, this is thickening around the biliary system. If a junior radiologist sees this, he will see the cholangiocarcinoma here, but it's not true. The clue is the thickening is smooth, as we see. Benign fibrosis, like any structure can cause benign fibrosis, even heterogenic. We can see here, but again, the thickening is smooth and regular, like this. And sometimes we can differentiate. We will go to histopathology. TB, the great mimickers. TB can manifest as any abnormality in the liver. Can like this, hepatic involvement, but the clue is had retrotoxin infiltrate in the lung. And again, the last is the mimickers of intraductal form. If we have caliculi in, if any cause, biogenic cholangitis, we have intraductal mets, IB, NB, all this will looks like the intraductal growing type. The stones will not have contrast enhancement, and there is association with parasites sometimes. We can see these stones. The clue for stones, it can moving from one investigation to the other. Here it first appear here, and then it become insect. This is the signal void characteristics. IBNB, it's look IBMN of the pancreas, but it has clues that you can see the mucin appear as hair-like structure inside the duct, like this. These characteristics for IBMN. Interductal mets, it's rare. The primary is mostly the chronic adenocarcinoma. In my career, I saw 2 times interductal mets from colorectal. We can see here irregular thickening with intraductal growth by ultrasound and diffusion restriction. The diagnostic dilemma, HCC versus mass-forming cholangiocarcinoma. There is typical form, as we said, and atypical form. The difficulty in differentiating the atypical form, because it lacks the fibrous stroma, so it will look like HCC. What we will depend on, we depend on alpha-fetoprotein, tumor markers, the growth pattern, and we can do histopathology. This is quiz. We can see this is man with H, let's be positive. What do you think? What do you think? Anyone? This is a T2 cloudy appearance. This is a clue for this case. Why cholangio? Cloudy appearance. What's it? What else? Looks, the portal vein is not infiltrated, it's encased. So it's cholangio. Second one. What's the clue? This is the arterial enhancement, and this is the delayed, aortovenous. This is intraductal growth. We agreed the intraductal growth, but the difference is the arterial enhancement and then wash out. So it's HCC. What do you think? It's 64 years old male, accidentally discovered hepatic focal lesion by ultrasound. It's typical appearance. Jailen. It's typical appearance. What do you think? It's cholangio. Cholangio have arterial enhancement, and this is the target. Look, this is target, diffusion restriction in the periphery. It's very characteristics for cholangio and the arterial enhancement with gradual filling in. What about this? It's 50 years old male, elevated liver and pancreatic enzyme. We can see there is smooth circumferential thickening around the common bile duct. So, what? Cholangitis, okay, it's IgG4. It's a part of cholangitis. And the last one, what do you think is there is growth around the gallbladder, neck, extending into the hepatic hilum with upstream dilatation? It's a great mimicker. It's gallbladder carcinoma extending along the biliary system. My type of take-home message is not simple as it seems. Everything in radiology is the same, so we must depend on other criteria like capsular traction, and please, not every capsular traction is cholangiocarcinoma. Not every prominent peripheral enhancement is hemangioma. And not every intrahepatic dilatation with cut-off is higher cholangiocarcinoma. Multimodality approach is our clue, and follow up with tumor markers. Thank you.
يعني كومنت، هل يا دكتورة في تواصل مع قسم الراديولوجي مع الجراحين والباثولوجيست عشان حضرتك شخصتي مثلا كولانجيو كارسينوما وانت قلتي جريت ميميكر وحاجات زي كده، عشان تعرفي ايه النتيجه علشان نحسن نفسنا ونبقى
بالظبط.
هل ده موجود؟
انا بسال يعني، انا لوحدي بحاول اتواصل معاهم، بس طبعا مش خلال سيستم،
لكن مش سيستم،
مش سيستم للاسف.
وهو والله يا ريت يبقى سيستم.
يا ريت بالذات الكولانجيو دي فعلا هي ملهاش باثولوجي قوي، ملهاش يعني ما اعرفش اخد منها مثلا عن طريق ERC مش عارف اوصل لها.
ايوه
ففعلا صعبه، والاي جي 4 بتاعها صعب.
هو لو في تواصل اعتقد الكل هيتقدم، يعني الجراح هيتقدم والباثولوجي هيتقدم
يا ريت حضرتك توصلنا بالهيباتوبيرالي بتاعهم
زمان، بس انا ما اعرفش لغايه دلوقتي موجود ولا لا. ايام ما كنا في التخصصي كان الهيباتوسيلر كارسينوما لها عياده بيحضرها الجراح والبطن والراديولوجي والباثولوجي كلهم موجودين. أيوة. مع بعض والعيان في وسطهم.
ايوه ليها.
هل ما زال موجود؟
انا اعرف ان ليها في الدبرداش ليها الهيباتوسيلر ليها. بس الكولانجي والحاجات اللي هي تبع البيرري دي ما اعرفش ليه مالهاش يعني
الحقيقه المفروض يبقى كده
فعلا في كل، اصل هي مالهاش حل غير كده. لازم بالفيدباك. بالظبط.
اتفضلي بيه.
شكرا يا دكتوره. The next speaker دكتوره ساره